with refugees and immigrants in this country living with AIDS, and that's what she's going to talk about today.
Great, thank you, Gretchen. So thank you all for being here today, all 4 of us, 6 of us, something like that. So as you can see from the title of my talk, I tried to hopefully pique your interest with this title, that global health comes home. And this is a talk about HIV in the foreign-born population and the work that I've done and that others have done, mainly that others have done, because people have done a lot of work in this arena. So I do have a lot of slides, so I'm going to kind of motor through, and I don't know if you all make the slides available, but I'm happy to share those. So first of all, some definitions. First of all, an immigrant is a foreign-born individual who voluntarily leaves his or her country of origin and has been admitted legally here in the United States, and usually they have legal permanent resident status, as opposed to a refugee who is a foreign-born individual who is unable or unwilling to return to their country of origin because of fear of persecution for a number of reasons, based on religion, based on political views, based on race, etc. An asylee is someone who is a refugee, who has a fear of persecution, but they are already here in the United States or at a port of entry, and they're asking to be allowed to come in. That's a asylee. So an asylee is not a person that is still in their home country. And then an unauthorized immigrant, of course, is the same as immigrant. They just haven't lawfully admitted and been allowed to come to the country. And that's the vast majority of people in this country, undocumented individuals, as it were. So this slide shows the actual and projected share of the U.S. population that foreign-born are. So you can see, yeah, this works. Okay, so in 2000, for example, foreign-born represented about 12% of the U.S. population. But if you look at what's happening here, that's expected to just continue to increase. So that by 2050, we're looking at about 83 million individuals who are foreign-born in the United States, or nearly 20% of the U.S. population. So that's pretty much doubling since 1840. So it's pretty tremendous, and thus this topic is pretty relevant for us. And then this just shows estimates of unauthorized immigrants here in the United States. This is from back in 2008. I'm sorry this is so old, but notably in Colorado, there was estimated at that time to be about 240,000. The big states with undocumented immigrants are, of course, Texas, California, Florida, New York. Not a big surprise. So what about foreign-born populations with HIV? So first of all, just some questions that I thought we'd ponder today, and I'll show you some information about. So one question is, are foreign-born persons bringing HIV to the United States? And how will immigration affect the U.S. HIV prevalence rates? Will it go up because of increased immigration with immigration reform, stay the same, go down, etc.? Is HIV different in foreign-born populations? Is there a reason to collect data about them in a specific way, specifically about foreign-born individuals? And do foreign-born individuals have different needs from U.S.-born individuals? I think we could all answer that pretty simply, yes. However, some of the answers to these questions, the short answer is that we don't really know. So there's limited and fragmented data out there that is about HIV-infected foreign-born individuals. It's skewed epidemiologic data. For example, when we collect data on HIV prevalence and incidence by ethnicity or race, then we're looking at the categories might include Hispanic, blacks, and so you can, and whites, but you can imagine that Africans are not then separated from African Americans. Latinos or foreign-born Latinos are not separated from U.S.-born Latinos. And we know that those populations are different. There's lack of outcomes data, similarly. Is that, again, what do we know about how people that are foreign-born do with HIV? Do they respond the same to HIV therapy? What are the factors that influence their outcomes? So we need some modification of data collection methods so that we could more accurately say what's happening in this population. And thus there's a need for prioritization of funding for research in this population. And then we need to refer foreign-born individuals to HIV clinical trials to help us gather this data. So this is a schematic showing what I just told you, that there's just a big gap in what we know in the foreign-born population. So I thought that I would just review really fast some data with regard to historically what's happened with individuals with HIV wanting to come to the United States. So for about 22 years, the U.S. Had regulations on travel and visa requirements such that if you were HIV positive, you were not allowed to enter the United States or obtain a visa to visit the United States without getting a waiver. And the waiver process was actually quite complicated. It was complex, it was time-consuming, and it did cost something for people. So, and HIV was listed among other illnesses as a public health concern, meaning that there was a risk to the U.S. public of these individuals coming in and spreading HIV to them. And this other diseases that were in this category were tuberculosis and syphilis. Now, obviously, as research data quickly evolved with regard to HIV and modes of transmission and also therapy in this country for HIV, it became quite clear to those people that do any HIV care, perhaps that just read, that HIV is probably not transmitted that easily from person to person, and rather this should not be in this category at all. And so there was a big move to change this, and you guys know what I'm getting at, I hope, is that finally the travel ban was lifted in January of 2010, such that there's no longer a waiver process. HIV is not in this list of diseases of public health significance. And so that's good news based on discrimination for these individuals, et cetera, et cetera. However, there's some issues with this as well, which I'm going to get into a little bit later. So before the travel ban was reversed, some folks at the CDC did a very elaborate research study that estimated the number of new HIV infections if the travel ban were lifted. And so I apologize, this is so complicated. However, what they did was they looked at the HIV estimates by regions of the world. So Africa, Asia, Europe, North America, Oceania, et cetera, et cetera. And they estimated a primary, a low, and a high, okay? And then, based on that, they came up with total population estimates of HIV from those countries and a rate, an HIV rate per 1,000 for populations in these countries. And then what they did is they estimated how many expected immigrants would be coming in to the United States legally with the travel ban being lifted. And the long and the short of it is what's circled here in the yellow, is the HIV rate per 1,000 immigrants entering the U.S. was felt to be about 4.06, or total 4,275 in 1 year. So this was not a huge number. It's just not a huge number. But it was the only number that we had. The only kind of data that was generated to this effect, and this helped. This document that was published on the CDC website and multiple other places helped to reverse the travel ban. And this is also from that same report. This is the estimates of HIV in immigrants over time after the change. And so does it change a whole lot? No, not a whole lot. It levels off the rate of HIV, the rate of foreign-born with HIV infection. And so still, this is total cumulative number of cases. So we're counting, each year is going to double if people are surviving. And then there's going to be some onward transmission of HIV, but there's actually not that much. And so if you can look, it kind of goes up and up and up over the first 7 to 10 years, and then it just stabilizes, as it would in any population in general. So this was again helpful to get the travel ban reversed. Similarly, the CDC investigators, this was Prosser and others, looked at what do we know about new diagnoses. So what about people that are already here that are foreign-born and new HIV diagnoses? And so what they did is that they looked at data on new HIV diagnoses from 31 states over a 5-year period. And there was a total, this is everybody, a total of 162,000 new HIV diagnoses. Of those, 15% approximately were foreign-born. And then what they did is they broke it up by gender and world region of origin. So this is males, this is females. And you can see that for males, the vast majority, or the majority of them, were from Central America. So that's what we see. This is folks coming from Honduras and El Salvador and Guatemala, for example, Belize. The next, and again, these are just males. The next most common category for foreign-born new HIV diagnoses was the Caribbean, so Haiti, Jamaica, etc., etc. However, look at females. Those numbers are a little bit different there. The vast majority of females are from the Caribbean. So again, Haiti, Dominican Republic, etc., etc. And then the next biggest category is Africa. And this is what I see in my practice, is that even here in Colorado, we actually have a lot of Africans here, and some Africans with HIV. This is always surprising to me when I think about it. I just think it's so strange. At any rate, then they went on to look at the HIV risk category for these people by gender. Okay, so males on top, females on the bottom with regard to this summary. And what they found was U.S.-born compared to foreign-born, that foreign-born individuals were less likely to have transmitted HIV by MSM, okay, more likely become infected with HIV by MSM, more likely to have been infected by heterosexual sex, less likely to become infected by IDU than U.S.-born. Okay, so heterosexual sex was much more common in foreign-born individuals in males. Similarly, for females, this was even more striking. So the vast majority of foreign-born females were infected by heterosexual contact. Very few, actually, by IDU. And again, this is what I see in my practice. Then they looked at the stage of HIV in U.S.-born versus foreign-born at the time of the stage of HIV. Meaning what they did was they looked at the time to progress to AIDS, so meaning their CD4 cell count went equal to or less than 200, or they had an AIDS-defining condition, and they compared this in foreign-born and U.S.-born. And the long and the short of it is it was more common to progress to AIDS more rapidly if you were foreign-born. What about here in Colorado? So this is just a quick pie chart showing as of June 2013 that about 10% of those living with HIV here in Colorado are foreign-born. 37% of those 10% are from Mexico, and 28% are from Africa. So a substantial amount. In 2012, there were 2,227 new HIV diagnoses in Colorado, and 15% of them are in foreign-born. And that number has increased just a little bit each year. about testing of foreign-born individuals. So are foreign-born individuals getting tested for HIV once they're already here? So this is a study from Seattle done by this African Immigrant Project. And they found, they surveyed folks, and they found that 35% of Africans surveyed said they had ever tested for HIV. Only 35%. But 70% said that they were willing to be tested. And then one of my colleagues here at the university, who you may know, Dr. Jose Castillo-Mancilla, he did a study just looking at Denver Latinas, so Hispanic women. And he looked at U.S.-born versus foreign-born, and he asked them if they had ever been tested. And he found that foreign-born, conversely, had been tested way more frequently than U.S.-born. 55% of foreign-born Latinas versus, I'm sorry, just misspoke. U.S.-born were way more common to have been tested than foreign-born. So again, just speaking to the fact that we need to be addressing this community and thinking about not only testing when they get here, testing when they're here already, because people are willing to, based on some studies. And then this is HIV testing in an STD clinic, kind of helping to inform the question: Are foreign-born bringing HIV with them, for example? So this is an STD clinic. They looked at their data for 6 years. They had tested in total 61,000 about patients. And that represented, and the U.S.-born represented about 1.8% tested HIV positive, and these were mainly African Americans. Foreign-born, 1.6% tested HIV positive. So not really any different. The majority of these were from Mexico and Central America, as you can imagine, in Los Angeles. So essentially the proportion of tests positive were equal in both these populations. And the average time for foreign-born living in the U.S. was about 12 years. So I talk about testing and I talk about continuous testing because I'm concerned about the risks for HIV for immigrants once they're already here. So minority groups in this country have an increased risk of HIV. African Americans and blacks have higher rates of HIV in this country. So does foreign-born put one at further increased risk for HIV once they're already here? So they get here, they're not HIV positive, presumably. And then now, are they going to get HIV, or they're at higher risk of getting HIV simply because they're here? So let's think about this. Estimating this risk, unfortunately, is complex, but really fascinating to think about. So bear with me while I kind of muse a little bit about this. So immigrants may originate from areas that have high HIV prevalence or low HIV prevalence. And so then they come here to the U.S., and that prevalence may be different. And so their risk may be changed from what it was before for that reason. So this is just some numbers. HIV prevalence. So South Africa, 18% of the country's got HIV. And I'm sorry, I don't have the date on this. I apologize. So that's the big number. Mozambique, 12.5, for example. Ukraine, 1.6. El Salvador, 0.8. About the U.S. data. U.S. is 0.6. Mexico, even lower than ours, 0.3. India, 0.3. Some of the numbers from the Asian countries are probably not very reliable because they haven't been reporting for very long, nor do they historically do it well. So anyway, I'm just showing you that people can be coming from different HIV prevalence areas. But, so that's one thing, is that you come from a high prevalence area to a low prevalence area, but says, okay, so that's a good thing, so maybe now your risk is lower. Or you come from a lower prevalence area than the United States, like Mexico, and what about what I call unintentional HIV serosorting? So let's think about this. So immigrants come from their country of origin, and they get settled, for example, if they're Ethiopian, many times, here in Denver, because there's a lot of Ethiopians here. There's Ethiopian churches, there's Ethiopian stores, there's Ethiopian restaurants. That's because there's a big community here. And so here they come into the Ethiopian community, and what they do, they don't go start shopping at Whole Foods in Cherry Creek. No, they stay in that area in Aurora, and they shop at Ethiopian African shops, and they go to Ethiopian Orthodox Christian churches, and thus they choose partners, their sexual partners, from this small, relatively, community that come from a higher prevalence area of HIV than ours. And so does that mean that then there's an even smaller pool of people that could be positive, and now we're not testing them? So we don't even know. They don't know. And so people are having, this thing keeps flashing, that's why I keep looking at it that way. So they could have an increased risk of HIV once they're here, just based on factors related to their immigration that may or may not have occurred in their country of origin. There's also the issue of isolation, and this is probably most true for Mexicans and Central Americans, but others as well. So they come here, and they're coming here for work, for example, these young, healthy men, and they're rural, they're migrant workers, they're away from their families and their children, and they're living in a house with 10 other guys, and they're going out every night after they've worked all day in the fields and carousing and engaging in risky behaviors that maybe they wouldn't be doing from their small town when they live in their small town in Mexico, because everybody would know about it, and then their wife would know about it. And so they may be at risk, and they may use substances because they're lonely. They may visit prostitutes. They may engage in sexual activity with other men that they wouldn't do otherwise. And so they may have increased risk of HIV as well. It is known that there's an increased representation of foreign-born individuals in jails and prisons, and incarceration is a risk factor for HIV. So there's another factor. And then mental illness among foreign-born. So we know that, for example, folks coming from African countries, often conflict-ridden African countries, have been exposed to some horrible things oftentimes. And they have PTSD, they have mood disorders, they have, among them, anxiety, there may be extreme violence, they may engage in behaviors that they wouldn't otherwise, become incarcerated, and so again, their risk may be increased for HIV. So what is it like living with HIV as an immigrant here in the United States? There's some unique issues. So first of all, there's a lack of HIV, good HIV information in this community regarding the modes of transmission, regarding treatment, and that it's available, regarding prognosis, because many people are not accustomed to thinking about HIV in the context of we can treat this and control it, but rather, oh, you have HIV, you're going to die. Some of the factors that weigh into this lack of information is illiteracy, there's language barriers, and so this is difficult. There's also a lack of knowledge and trust in the U.S. care systems. That, many times people don't understand how this works. Where do we go? We can get care. What is an appointment time? What does that mean? What do I do when my prescription runs out? Oh, I thought it was done. I didn't know if I needed to continue, etc. There's disclosure issues. There's denial and stigma surrounding HIV. There's cultural and religious practices. And then there's lack of health care for people that without any work, for example, or whose employers don't offer health insurance, for example, and hopefully these things will be changing. So this is a study out of the Midwest. I think this is in Minnesota. Can't remember now. They looked at the HIV education needs for Sudanese immigrants and refugees. And these is what they found. 55% thought that HIV was transmitted by mosquitoes. 40% thought that it could be transmitted by a cough or a sneeze. Equally, 40% thought you could get HIV from a bathroom. And 55% thought that having sex with someone that looked healthy would protect them against HIV. 36% that HIV was a punishment from God, and a larger portion of them engaged in risky behavior. So this is just one example. There's numerous studies out that show similar kinds of data. Some clinical issues that are relevant for those of you who are clinicians is that, number one, HIV-2, so there's HIV-1 and there's HIV-2. HIV-2 is more common in folks from West Africa. And that disease is very different than HIV-1, and it's treated very, very differently. A whole class of HIV medications that we use commonly for HIV-1 does not work in HIV-2. There's also no way to test HIV viral load. That's one of the things that we do in clinical practice, is that we want to know how much virus is in somebody's blood, but there's no quantitative tests of HIV-2 available in this country, nor is there any resistance testing. So here, when someone has a problem with their regimen that it doesn't seem to be working, we check a resistance test to see if they are resistant to the medicines that they're on, but we can't do that for people that are HIV-2. So there's a lot of guessing that occurs. There's also not much known about their outcomes and response to therapy in general, especially with the newer HIV medications. Similarly, the most common type of HIV here in the United States is subtype B. However, there's multiple other subtypes, C and D and E, for example, and those are more common in other parts of the world, again in African countries and other countries. And so that can lead to difficulties in diagnosis. Some of the tests that we do to make the diagnosis of HIV are not as good to pick up on these illnesses or these types of HIV. There also may be differing risks of opportunistic infections and other comorbidities. So tropical illness that we don't see very much in U.S.-born populations is more common. So things like tuberculosis, of course, Kaposi sarcoma, but also trypanosomiasis. That's something that happens in Africa and South America. Leishmaniasis, same kind of epidemiology. Strongyloidiasis, schistosomiasis, I just like saying iasis, obviously, and hepatitis B. So these things are just things that we need to have on our radar screen as far as clinicians in caring for these people. There's also issues with regard to the use of HIV medications and pharmacogenetics. So differences based on race and ethnicity for how one metabolizes drugs, and thus how well the drugs will work, or toxicity. So there's emerging a lot of good data looking at differences in African Americans as opposed to whites or Hispanics in the use of certain HIV medications. Some other specific issues that may be relevant are, for example, complications and long-term sequelae of genital mutilation. We've seen this in our clinic. Women that are having a lot of different problems. Different childbearing customs and cultural pressures for childbearing. So folks are expected in many of these cultures to to get married, to have children, to have a lot of children, and to breastfeed those children, which is not something that's done in HIV-positive women, for example, the breastfeeding part, that is. And then the mental health issues that I talked about. With regard to mental health and foreign-born with HIV, this is a study that looked at psychological, psychosocial, and physical health functioning in almost 100 folks, HIV-positive refugees, Latinos, and U.S.-born. And they assessed for their level of acculturation and immigrant-related stigma. Here's the citation. And what they found was, compared to the other groups, the refugees had more traumatic experiences, had more psychological stress on measures of traumatic events. So when they asked them what had happened, they had lots of measures of becoming very stressed out about it, of stigma related to their HIV. Social support within the community was decreased. They didn't feel like they could talk to anyone. They reported significant isolation because of their HIV. And so they just said, these are barriers to health care, and we need to be addressing these things. And again, there's multiple studies that have looked at these aspects. I thought I'd share some cases. These are true cases with the names changed of my patients. So first of all, Bala is a 27-year-old female who's from Liberia. And she had an HIV test as part of the immigration processes before the lifting of the travel ban. And she was found to be positive. She was granted a waiver to come to the United States, and she came over with her dad and her stepmother. And she'd never been tested for HIV before. When they got here and got settled in their new community, her stepmother proceeded to tell everyone in the community that she had HIV. So she was ostracized. Obviously, she didn't ask Bala if that was okay. So she, I say here that she cut ties with her family, but really she did that because her stepmother was being so horrible to her, and basically wouldn't really let her move freely in the house, wouldn't let her cook, wouldn't let her do anything. So she just stopped, moved out from the house where she had been living with them initially, and then didn't have any contact with them after a while. And then she later learned that they had moved to Nebraska without even letting her know. So she was very, very lonely. She began dating an HIV negative African American man, excuse me, that's a typo, but was afraid to disclose her status, and we talked about this every time. She's also got hepatitis B, by the way. They were dating for about 6 months and having unprotected intercourse when she finally told him she was HIV positive, and he was very mad, of course, and ended the relationship. She was really lonely. She was talking to some people in her community that hadn't heard about her HIV status, and they were all asking her when she was going to get married. She's a young, beautiful girl. And she really wanted to have children, and she had been talking to her mom at home in Liberia, who said, when are you going to get married? When are you going to have children? I want my grandchildren. So then she met an African man and became engaged to him, but did not disclose her HIV. Once she was pregnant, she decided to disclose, and she told me this. She said, when I get pregnant, then I'm going to tell him that I had HIV. This is really tough. Every single time I saw her in the clinic, I'd say, please, Bala, you've got to tell your husband before you get pregnant. Well, anyway, she finally disclosed when she was pregnant, and he was really mad, of course. He came into her appointment with her, and I talked to him, and we all talked together, and they tried to work things out for a bit, but basically after she delivered an HIV negative baby girl, they separated and eventually divorced. And she has custody of her now 4-year-old daughter, and he is now married again to another African lady, living in the house that he had bought them, and is trying to get more custody of their child. Now, Bala is engaged to her previous African-American boyfriend, and they don't discuss the HIV, nor do they use condoms. So this is kind of the ongoing saga of what's happening with Bala. So, just the stigma of HIV, I give this case just the stigma of HIV is so powerful. HIV is shameful. It's a death sentence. People don't talk about it. It prevents us from accurately, from giving good information to the community, and then it promotes the spread, as you can see, of HIV in communities. And notably, the African man she married did not become HIV infected, despite their time together. I think I've already hit on this. So the next case illustrates a different concept. Another one of my patients, Francois, was 24 when she was still living in Rwanda, and she is Tutsi and her husband is Hutu. And that's never been an issue for the couple or their families. Everybody was fine with that. So during the war, they were separated, and they both thought the other one was dead. And Francois was hiding in a church when it was ambushed by rebels, and she was raped. She managed to escape, got to a refugee camp, and reunited with her husband, wherein they both applied to become refugees, to come to the United States as refugees. And so as part of that process, they had HIV testing. Again, this is before the lifting of the travel ban. She was found to be positive. He was negative. And she had never had any other sexual partners, no blood products, no other risk factors. So they came together to Denver, and she enrolled in an HIV treatment trial and got free medications, took her medications every single day, did really, really well. Her husband was very, very supportive. And as of about 6 months ago, they had worked at the same job for like 5 years that I've known her. They both have learned English, and they're trying to get pregnant. They have 3 other children that came with them. They're trying to get pregnant by insemination in order to keep him safe. So they are, you know, a success story of immigrants coming to the United States and doing really, really well, and being very motivated to do well. So rape as a weapon of war is extremely important with regard to HIV. This is a quote, "We are not killing you, we are giving you something worse. You will die a slow death." This is what mercenaries who raped and mutilated Tutsi women, some as young as age 12, after killing the menfolk, chanted to them. In Rwanda, during the genocide, about 80% of women that opted for HIV testing were HIV positive. Some other aspects with regard to care of this population is Western versus traditional medicine, and the belief in things that are not so accepted here in the United States. So first of all, just the difficulty of accepting the HIV diagnoses without symptoms. That's not a new concept or a unique concept, I guess. Belief that they will be cured by God or a higher power. I definitely see this a lot more commonly in my African immigrants and my Latino immigrants, that holy water and that going to church and that praying and visiting sacred sites in their home country, for example, will cure them. And it's very, very common that people will go on medications and then they'll go home to their home country and visit some site, and then they'll stop their medications because they firmly believe that they have been cured from their HIV. And this is a study that actually surveyed Africans about their beliefs with regard to HIV. So where they thought HIV came from, for example. So I'm under a spell, some kind of witchcraft that was done to me. My girlfriend, boyfriend, wife, husband is negative, so that means it's a bad spirit or witchcraft. Would my sexual partner have it too? People wanting to make money put this spell on me, and then again looking for traditional medicine to cure them. There's also financial concerns for immigrants. Because they don't understand necessarily our U.S. system, they may feel that they may not know that there is free HIV testing available extensively in Denver and throughout other parts of Colorado. One big aspect is low-paying jobs that don't offer health insurance. Again, hopefully this is going to change, but also extreme work schedules, all-night shifts, or not having any days off except for Sunday, and not being able to make it into the clinic in normal clinic hours. So the idea of after-hours clinics are really important in this population. And then sending money back home, that's often a priority. I see this a lot, that people are working and working and working and working, and it's because they're sending all that money back home. And then confidentiality is huge, as you can imagine. So because the size of the community is so small, people are very concerned about this. They're very concerned about being seen in the clinic by somebody from their community. I have one lady who, she's about this tall, and she weighs about 75 pounds, and she comes in, she's from Ethiopia, and she comes in and she wraps her head all up, and she wears these huge sunglasses, and she wears these baggy clothes, and she just completely conceals herself. And before she, in the exam room, before, she takes everything off, and then before she leaves the exam room, she puts it all back on, and it's this big production. And she says every time, I can't have anyone see me, because there are a lot of Ethiopians. To this end, many, specifically African immigrants, will refuse the use of translators because of this issue. They do not want to have someone from their church that ends up being the translator. So this is a problem. And I think this is my last case, another patient of mine. So Sarah, she's a 46-year-old woman, and she's from Eritrea. And she served as a freedom fighter, and she sustained multiple gunshot wounds. So in the civil war between Eritrea and Ethiopia, there was a lot of female freedom fighters. Her husband, unfortunately, was killed in the war many years ago. So she came to the United States about 15 years ago as a refugee, and many of her family members came with her, and they all live very, very closely in this house together. Her brother comes with her to all of her medical appointments. And see, she's actually, I've been taking care of her about 10 years now. She actually has gone home a couple of times now and stayed for a year, and her brother sent her medications to her, and everything went fine, as opposed to another patient of mine from West Africa, a single guy who had his friend picking up his medications supposedly and sending them to him, and he never got his medications. And he ended up failing his HIV regimen because of that lapse in therapy that was, I think, about 6 months. And so it was just, and it happened about the same time that she went and took her medicines and came back and everything was fine. So it was just, it's kind of horrible to see these two together and know that things should have been different for him. At any rate, for Sarah and for Jean-Jacques is the gentleman's name, engagement and care is something that's been really great. So many of these patients actually find the clinic to be a safe zone where they can talk freely about their HIV, and it may be the only safe zone they have. They may not talk to anyone else about HIV ever in their whole lives. Every 3 or 4 months when they come in is the time. Or some of these patients want to come and see me about every month, because, not really because I need to do anything for them every month, but because they like coming into the clinic. Conversely, some people don't want to come in because they don't want to be reminded of their HIV, and that's common, foreign-born or U.S.-born. So there is a high rate of compliance with medical visits and with medications in general. There's immense gratitude, and it's important that providers have a relationship with this population and their cultural context, and just keeping in mind the things that we learn about with regard to cultural competency. One of the things that is really big is fasting in this community, whether it's Muslim fasting for Ramadan or Ethiopian Orthodox. There's a lot of holidays in Ethiopian Orthodox. I don't know if you guys are familiar, but they don't have any dairy. Well, many of them just fast completely, or they won't have any dairy, meat, eggs, anything all day long until they break their fast, and it's multiple times during the year. And then of course they won't take their medicines during that time either, which can be a problem. Okay, and so in the last few minutes that I have, I'm going to talk about our foreign-born program at the University of Colorado. So we're seeking to basically improve the care of foreign-born individuals. We want to improve all kinds of outcomes, morbidity, mortality. We want to keep people in care. We want to increase their rates of satisfaction with care, and we want to provide them information about HIV treatment and prevention. In order to fill the gaps in the knowledge of HIV in this population, we'd like to create a longitudinal foreign-born database. We have one kind of, That would be me collecting data. So that's the kind of part of this. And we'd like to develop more clinical research projects in immigrant health and HIV. So these are the aspects of the program: HIV primary care and treatment, specialized women's services, psychosocial care program, specifically for PTSD, mood disorders. We also do immigration medical exams and document preparation assistance. So when someone's a refugee, after a time they've got to apply for legal permanent residency status, their green card, or conversely, if you have a green card, it's got to be renewed every 10 years, and you have to have a medical examination by a U.S. State Department designated civil surgeon to make sure that, again, you don't have any of these diseases of public health significance. So I'm one of those civil surgeons, and so I can fill out this paperwork for them, and our social workers then help them process the paperwork the appropriate way, because it's actually a very complicated process. What was happening is that we found that immigrants were going elsewhere to see civil surgeons, and they were having repeat tests things that we'd been doing already as part of their clinical care, paying for all this out of pocket, and they were getting vaccines that they shouldn't based on their HIV. So live vaccines that they shouldn't be getting, for example, because their CD4 counts were too low. We have clinical trials, of course, the AIDS Clinical Trials Group, etc. Prevention strategies. We also do pre- and post-travel foreign travel medical care. So if they're going back home to the Congo, for example, for the first time, they're at risk for malaria, just like you or me. They haven't been there for 5 or 10 years. They don't have immunity to malaria anymore. They need to take malaria prophylaxis just like we would. Or they're going to Angola, and Angola is you have to have a yellow fever, documentation of yellow fever vaccine before you can enter the country. And so these are things that we do for them. And then post-travel too, you know, if someone is ill from a tropical illness, for example. We also have a reproductive care program, including fertility services. So I mentioned insemination. We do sperm washing. You guys may have heard about in efforts to help individuals that are HIV serodiscordant. So one partner's positive, one partner's negative, to get pregnant safely, so that the baby is then safe too, depending on who's positive. And then at our MCPN clinic and Grand Junction clinic, we provide care for undocumented HIV-positive immigrants. Not here, but those are the two places. And so the satellite clinics are Grand Junction, Pueblo, Durango, and then the MCPN in Aurora, and also Fort Collins, in addition to the clinic here at the university. So here is the program demographics, and these are from about 2010. About 150 foreign-born, representing about 10% of the HIV clinic populations. This is data for Denver and Grand Junction only. Women represented about 39% of these foreign-born individuals. 20% of them were refugees. There were 46 different countries represented among our foreign-born population. Again, I think that's so crazy for here in Denver. So Africa, Latin America, and Caribbean were most common, but we also have a fair number of Asians, specifically Burmese. HIV risk factor most commonly was heterosexual sex, MSM, very, very less commonly IDU. We do have a fair number of people that it appears that their risk factor was either rape or with a needle stick, blood transfusion, blood products, things like that we could not uncover any other risk factor. The reason that the vast majority were tested for HIV in the first place was illness or immigration. Also, their partner had been positive for pregnancy. About 22% of them had had an opportunistic infection, of which most of it was tuberculosis. Their mean CD4 count was about 502, which is a normal CD4 count. And the vast majority of them were on antiretroviral therapy. So, just for the last few minutes, I don't even know how many slides I have left, I thought I would talk about some of the issues with regard to what I foresee, what I what I think is an increased risk of HIV for foreign-born populations. The first thing is, I think that HIV testing is crucial. I don't think that it should be listed as a disease of public health significance, but I think for this population, we need to continue testing. But we need to either not have it be in the list of diseases of public health significance to stay the same, or make the waiver system better. So I'm not suggesting that we put back the travel ban. I'm just saying that there needs to be a way to test these people so that we know, so they can get care. They're coming here. It shouldn't preclude them from coming here. And in fact, it should help them to come here. Well, we should be helping with that process. In the United States, refugees have to have a medical exam when they enter the country and are settled. And so I think that if they come from high prevalence areas, they should continue to be tested for HIV if that wasn't done before they left. And then there also needs to be prioritization of testing these individuals when they present to medical care settings in general. And the CDC now recommends, the guidelines are for HIV testing for all adults essentially when they enter a medical care system in reasonably HIV prevalent areas. So this is in line with CDC guidelines for the general population, but it's even more important for for immigrant populations. To this end, with regard to increasing testing, I think that involvement of community-based organizations is really, really critical. So things like resettlement agencies, churches, church and community leaders, to get a buy-in for the need for testing of this community and to make it okay to destigmatize HIV. So we need more education of this population about risk factors, risk reduction strategies, what the healthcare system looks like in the United States, what the HIV treatment and care system looks like in the United States. And we need money to do this, of course. Some future directions. Dr. Jose Castillo and I have been really interested in the idea of a national HIV foreign-born registry, which could look like this: a multi-site consortium where clinical data is collected prospectively and in real time to monitor trends and needs of HIV individuals and to fill in these knowledge gaps and to help inform where money goes. And then also another kind of wish list thing would be an immigrant HIV provider network that could share data, that could have educational platforms, e-clinical consultation, blogging, things like this, just an area of support for HIV providers who take care of large numbers of foreign-born individuals. So that's what I have. Questions? Comments? Yes?
This is a wonderful talk. I was really struck by one of your earlier slides when you showed sort of the projections for sort of the increased growth of immigrants in the United States, and it kind of reminded me of like in the early 90s when I was applying medical schools, and I saw they were showing sort of similar projections with the Latino communities in the United States. And,
yeah.
You know how traditionally in this country, you know, African Americans have been the minority nationwide. Now it's Latinos, like in Colorado, for example. I read that Colorado is approaching like 25% of the state being Latino. Right. So we're actually seeing these projections over time. Maybe it speaks to just how old I'm getting. So I was kind of curious. So the model here is you see Denver for immigrant patients. So let's say, and maybe I'd like you to kind of educate me a little bit about sort of this distinction between immigrant versus refugees and those other fine points. So let's say that I am an immigrant or a refugee that comes to Colorado today. You know, what would be the process if I was HIV positive for getting you know, seen by a specialist? Let's say I didn't have any health insurance.
Yeah.
And getting medications over a lifetime or even a condensed period of time. You know, whether I'm immigrant versus refugee, and I know that UC Denver gets a lot of Ryan White funding to subsidize care. But I was curious to know also through your thoughts about, like, do you feel that that's sustainable for refugees, let's say 10 years from now, if their healthcare is being subsidized? Like, will they need to find jobs, or can they be?
No, they are finding jobs.
Yeah, okay.
Yeah. So the answer to your question is that it kind of depends. First of all, so the designation between immigrant and refugee doesn't really matter with regard to the care. The designation that really is important is with regard to immigrant is that are they here legally or not?
Okay.
So if they're here legally, here in Denver, in the metropolitan area of Denver, if they are legal immigrants and they're HIV positive, if they live in Denver County, then they can go and get their HIV care at Denver Health. And they will, and they fall under that Ryan White funding, where they can be seen and they can get medications. If they live outside of Denver, then they can come here. So that's how that works. So the vast majority of people that we see are from Aurora, for example. And so they can come here, they can see me, they apply for what's called the CICP program, Colorado Indigent Care Network. And so that allows them to be seen in our clinic by me. And it allows them to be seen in many other clinics in the hospital, but it doesn't allow for things like surgeries. It doesn't allow for mammograms, colonoscopies, any of those things that cost a lot of money, because those subspecialties don't get paid by the CICP. And none of that falls under Ryan White. So the way that our HIV clinic is able to see these people that only have CICP is because of our subsidization with Ryan White to provide for salaries, provider salaries, because the CICP amount that we're getting back wouldn't allow for that with regard to sustaining the clinic and manpower. They will get, if they get CICP, and that's based on income and documentation, etc., then they usually can then also be accepted into what's called ADAP, the AIDS Drug Assistance Program. And so that is a nationwide program that's administered by each state, and HIV medications are on there. Basically all HIV medications are on there. So you can get therapy. You just have to renew that and your CICP. Now, the ADAP is every 6 months. The CICP is every year. So this is how it has worked. If you're undocumented and you have HIV here in the Denver metro area, then basically, to my knowledge, and you live outside of Denver, then the only place you could go is the MCPN clinic in Aurora, which is up the road, which Dr. Castillo started in 2009. And so there's about 100 patients now, and I'm the doc there now, along with the PA. So every Thursday we have a clinic, and we're accepting new patients, Thursday afternoon. So if you're undocumented, HIV positive, live outside of Denver County. If you're undocumented, live in Denver and HIV positive, you can go to Denver Health.
Can those undocumented folks that come to MCPN get meds?
They can get meds. They can get ADAP. Yeah, there's something special about the MCPN model that they're able to do that, but the university won't. Now, at MCPN though, there is a paucity of availability of subspecialty services. So it's a community, MCPN is Metro Community Provider Network. So that's an outpatient setting. They don't have their own hospitals, et cetera, et cetera. So for example, I have a patient from Mexico that was just diagnosed fairly recently with AIDS, disseminated histoplasmosis, Mycobacterium avium complex, and a lesion on his leg that we didn't know was going to be fungal or what, and was growing, and finally it grew so much he came to the university, got admitted, and thankfully now is getting a biopsy of this thing because I couldn't get a biopsy for him. Because he would have to come here to see dermatology and pay out of pocket. Just to be seen was $400. So now he's admitted, And we think he has visceral Kaposi sarcoma here and then visceral. And so now the question is, how are we going to get him chemotherapy? He's undocumented. And so we're exploring the idea of emergency Medicaid, because if he does have visceral KS, he must have chemotherapy. So anyway, that's just a very pronounced example of some of the difficulties.
How often do you see patients that take advantage of like assistance programs through like Gilead or things like that to get medications?
Yeah, we do that a lot. We do that a lot.
And
Definitely.
documented versus undocumented?
I don't know if you have to be documented for
I don't
those
think
things.
you do, honestly.
I don't think you do either.
Okay.
Yeah, I don't think you do. I haven't been doing the MCPN clinic that long, so I don't know the ins and outs of the undocumented. So historically, because I've just been here, I don't know how that's worked. I'm still learning. And then obviously all of this is going to change. So we keep saying that. All of this is going to change, and we don't know what it's going to look like, and we've been saying that for like the past year. So, but you know, rolling people over into Medicaid and parts and things, Part D and Part C and Part all of that. But, so, my email address is the usual university system, monica.carten@ucdenver.edu. And I assume Molly's going to post something.
Yep, the slides will be posted on the lecture series website, the Center for Global Health, along with a recording of the talk if you wanted to recommend it to a colleague. But thank you for braving the weather, and thank you for braving the weather.